This is a presentation on sudden cardiac death in pediatrics geared towards EMS providers. By the end of this module, you should understand the statistics and characteristics of sudden cardiac death in pediatrics. You would be able to list the major reasons for sudden cardiac death, and this relates to the physiology. We will review case-based examples, and at the last, we will consider effective strategies for you to improve survival in your community. First of all, statistical characteristics. In the pediatric population, there are approximately 2.28 sudden cardiac deaths per 100,000 patient years or person years. 2,000 deaths in the United States occur each year, and the highest age groups affected are infants and adolescents. Athletes are certainly at higher risk for several reasons, and the National Center for Catastrophic Sports Injury Research reports about 16 fatalities related to football in the year 2023. So if the numbers are so, why is it so important? Well, number one, there is a higher proportion of athletes involved in sudden cardiac death or susceptible to sudden cardiac death, and these deaths are high profile. They have implications for the families, as many of these conditions are inherited, and it's definitely emotional for the community. So, who else dies of sudden cardiac death? Well, children who have had repaired congenital heart disease are also at risk. These numbers are a little bit dated, but it shows that aortic stenosis or left ventricular outflow tract narrowing and detransposition of the great arteries are two of the highest disease categories with congenital heart disease and sudden cardiac death. In DTGA, the coronary arteries are reimplanted from the one great vessel to the other, and that can make the coronaries susceptible to kinking and compromise. And in aortic stenosis, the left ventricular outflow tract being narrowed puts the patient at risk. So if we look at characteristics of sudden cardiac death in young athletes, males have a higher rate of sudden cardiac death than females in athletes. Basketball and football comprise 2/3 of the cases of sudden cardiac death. Although sudden cardiac death is sort of pictured as a death on the field during exercise, it can also occur 30 minutes or so after exercise. It is typically more common in formal practice, although it's questionable whether this is reporting bias. And most frequent hours of sudden cardiac death in athletes sort of correspond to practice and game times between 3 and 9 p.m. And the patients with sudden cardiac death typically will have a higher risk of having some sort of either known or undiscovered yet structural heart disease. Many of these episodes of sudden cardiac death in pediatrics will have triggering events which require some sort of structural substrate and may be related to autonomic function. Acidosis can come into play, low potassium, which may be seen more frequently in athletes who may be somewhat dehydrated, increased adrenergic state, the high adrenaline of competition, and then lastly, some types of congenital heart disease or structural heart disease like hypertrophic cardiomyopathy do not tolerate dehydration or hypovolemia very well. So that's kind of if we move on to look at what's really happening in the heart during sudden cardiac death, break it down into like, why does anyone have cardiac arrest or sudden cardiac death? And it comes down to cardiac output. There's a lack of cardiac output, which can be related to heart rate if there's a disorganized or too fast rhythm. the heart rate can be ineffective. If a patient has a asystole or high-level heart block, the heart rate may be too slow to support cardiac output, and the stroke volume can be affected by poor ventricular function or structural defects. So if we look at the heart as a pump, you could have pump failure where the myocardium or the muscle is not effectively pumping. So the muscle here could be ineffective. The conduction system, consisting of the sinus node, the AV node, and the ventricular His-Purkinje system, can be defective. You can have too slow or too fast of a rhythm. And then lastly, valve obstruction speaks to especially left ventricular sided obstruction, like the aortic or the mitral valve can be obstructed, and that can cause poor cardiac output. If you break it down into these three sort of physiological reasons and look at the pump, hypertrophic cardiomyopathy, which is a congenital condition, is one of the highest causes for sudden cardiac death. Dilated cardiomyopathy, which is an acquired heart problem from usually a viral infection, and coronary artery insufficiency. Usually in kids, this is some sort of congenital abnormality where the left coronary does not come off the aorta properly. In the electrical arena, Wolff-Parkinson-White is not only responsible for supraventricular tachycardia, but can cause sudden cardiac death because it can lead to ventricular fibrillation. Commotio cordis is relatively infrequent, but is becoming more known and perhaps more recognized. Long QT syndrome, all of these are electrical abnormalities. And then valve obstruction would be known because of the patient having congenital heart disease or some sort of acquired aortic disease. You look at hypertrophic cardiomyopathy and coronary artery abnormalities. Together, these two conditions comprise 50% of all cases of pediatric sudden cardiac death. If you add dilated cardiomyopathy, then you've covered about 75% of all cases. We won't discuss all of the cases or all of the diagnoses listed here, but we'll give you an overview of all of these. So moving on to the case-based scenarios. Case is clearly one that's been talked about in the news in recent years. A 24-year-old male collapses on the football field. He has no prior cardiac history. So what is the differential diagnosis and what do you do? This is a pretty famous case of Damar Hamlin, who collapsed when he was struck with an elbow in the chest. So he received the diagnosis of commotio cordis. So I want to talk about just fast facts. It's typically due to ventricular fibrillation, ventricular tachycardia, or complete heart block. These are the most frequently precipitated arrhythmias leading to commotio cordis. The sports that are typically involved include baseball, football, lacrosse, and hockey. In fact, with baseball, the commotio cordis is responsible for the highest number of on-field sudden cardiac death. Commotio cordis typically requires a dense projectile, like a baseball or a hockey puck, to hit the chest at a vulnerable time of the electrocardiogram or on the upstroke of the T wave. Interestingly, although there are many commercial chest protectors available, in a study of how protective these chest protectors were for preventing commotio cordis in a laboratory setting, many of them were not helpful. And then survival is really due to two factors. One is rapid resuscitation, and this requires rapid recognition. Typically, these survivors have been resuscitated within 2 to 3 minutes of collapse. and it is also associated with having an AED on site. If we look at some of the published data on commotio cordis, we see that the survival rate in the United States per the registry is about 15% of all patients who collapse on the field with commotio cordis. This is generally due to lack of recognition and failure to initiate a timely aggressive resuscitation, including defibrillation. Survival is favored when CPR and defibrillation is instituted within 3 minutes of collapse. An animal model shows that if defibrillation with an AED is performed within 1 to 2 minutes of onset of ventricular fibrillation, that within 1 minute you can have 100% successful resuscitation, and within 2 minutes, 92% successful resuscitation of a patient or an animal model with ventricular fibrillation by commotio cordis. Only 46% of these animals are successfully resuscitated after only 4 minutes, and only 25% survival rate is recorded after 6 minutes. It was shown that the AED was very effective, having a 98% sensitivity for recognition of ventricular fibrillation, and it was specific for non-shockable rhythms at 100%. So if you recall back to a previous slide, you can have complete heart block in someone who's experienced commotio cordis, and this would require effective CPR. So in saving lives with commotio cordis, this data supports access to AEDs at organized youth sporting events, and also training for early use would increase survival. So the AED is an integral part. So if we talk about animal model, I'd like to sort of review some of these tracings and how we know some of this information. This is a tracing that has EKG leads, lead 1 through 3, ABR, L, and F, recorded here on each line. There is a tracing here of the pressure tracing in the left ventricle, and you can see the moment of impact when the projectile hits the animal. So this is actually a swine model where they had 11 kilogram swines to sort of mimic the compressibility of a child's flexible chest, and they would hit them in the chest with different projectiles at 30 miles per hour, and they had a way to time the hitting of the projectile on the chest to the EKG, and this is where they defined the vulnerable period is about 20 milliseconds in the upstroke of the T wave on the EKG. A recent article came out in the American Journal of Cardiology, where Barry Marin and Mark Estes, two specialists in sudden cardiac death, reviewed the case of Damar Hamlin. If we look at from this article, they looked at commotio cordis, which is much more common in kids, thought to be because their chest is really flexible. So it's the elements that you have to have for commotio cordis to occur is a precordial impact, and that is typically just to the left of the sternum, and it has to somehow be timed at the vulnerable period of the cardiac cycle. And so here you see the EKG at the bottom, where this demonstrates the vulnerable time of the EKG, and then when the projectile hits this flexible chest, it can transmit that energy into the left ventricle, and usually will start VFib. So the hardest projectiles like hockey pucks and lacrosse balls that are solid, there is a report of just a fist on the chest causing commotio cordis and death. but they have gone to softballs that have a softer core that's more compressible and have shown that that is a bit safer, but with a hard baseball, can't mitigate the risk of commotio cordis. This is a diagram from the same paper showing that most of the events occur during competitive sports or supervised events rather than just recreational sports. The exceptions are hockey, which is all competitive, and then boxing has a little higher rate during recreational boxing. This looks at the age of the child at the event and shows that the worst risk for survival is a child less than 10 years of age. So after 11 days in the hospital and extensive rehab and recovery and investigation, Hamlin has returned to play professional football. Okay, case number 2. There's a 15-year-old male who collapsed on a basketball court during basketball camp. They've been doing long practices on hot days, and his friends say he had to stop frequently to rest. So this is a typical vignette of one of the most common causes of sudden cardiac death. It would be hypertrophic cardiomyopathy. In hypertrophic cardiomyopathy, the symptoms include chest pain, which is typically exertional, shortness of breath, dizziness. A heart murmur can be detected, and oftentimes these patients have fatigue, or they may self-limit their exertion, and sometimes they complain of palpitations. These are pretty specific for hypertrophic cardiomyopathy, but they are also seen in all sorts of other conditions. So not really until you put it all together helpful to making the diagnosis. So this is the most common cause of sudden death in people under the age of 35 years. It's inherited, but typically the thickening of the heart muscle develops over time. So if a family history is known, these kids may have completely normal hearts until they reach puberty. It's often death in these patients is associated with. So if we look at the EKG, there are early changes that occur. And even before you begin to see high voltage, these patients will have a progressive T-wave abnormality or T-wave changes. Here's another case which was published where they showed that it's reliable to predict hypertrophic cardiomyopathy by the resting EKG. These have abnormal T waves. They're not like a nice upright curve, and high voltage. So EKG is a pretty sensitive way to diagnose hypertrophic cardiomyopathy. This is a pathological specimen of a patient with hypertrophic cardiomyopathy showing a thickened heart muscle compared to a normal heart muscle on this side. This is the mitral valve. This is the tricuspid valve. This is the right ventricle, and you can see that most of the hypertrophy occurs in the left side and the interventricular septum. These lighter areas are areas of subendocardial ischemia, and so the problem with hypertrophic cardiomyopathy, and probably why it is one of the most common reasons why for sudden death in the young group, is that this thick muscle has the same coronary artery distribution, so they're at risk for what we would call a watershed ischemia. This is not a thickened heart muscle like an athlete would have, but the cardiac muscle fibers are not uniform. They occur in whorls and swirls instead of nice organized sheets. And so they're with this irregular electrical signal traveling through this abnormal heart muscle, there's a risk for VT and VFib. And then there is a restrictive physiology. If you go back to is going to have a harder time with filling, and so that will cause the atria to be dilated, and atrial fibrillation or flutter can occur in these patients, and it will typically quickly deteriorate into worse risk. So resuscitation in the field for suspected hypertrophic cardiomyopathy can include fluids. So this patient clearly with long practices and hot days is likely dehydrated. So with hypertrophic cardiomyopathy, this patient is going to require preload. They need high quality CPR, and if there is a recorded rhythm that's shockable, then correcting any type of rhythm as quickly as possible is indicated. The next case is that of a 9-year-old female who mother found seizing just as the alarm clock went off. So she calls you, and you decide to transport her to the emergency department. And en route, she's chatting with you. You see this on the monitor. So this rhythm, can you name the rhythm? This rhythm is torsade de pointe. It is a typical rhythm for long QT, which is the most likely condition, and your next step would be shocker. This is a shockable rhythm. This is essentially a special form of VFib. CPR. Magnesium sulfate can help to stabilize the rhythm, and then it is also important to get a recording of the rhythm and head to the nearest hospital. This rhythm is called torsade de pointe, and it is the typical rhythm of underlying long QT syndrome. Interestingly, in adults, most people with long QT who've reached the adult stage have had some sort of syncopal event, or I've heard adults talk about having a brownout where they almost passed out but didn't quite. And then in pediatrics, children are much more likely to have sudden cardiac death or sudden cardiac arrest as their first symptom. So how do you tell long QT? Long QT is where this repolarization, or the T wave between the Q and the T interval, as you can see by that little tick mark, that takes longer than usual, and that's a vulnerable time of the cardiac. For a quick glance at the EKG, if the T wave is completely back to baseline before the halfway mark between two QRS complexes, that's typically a normal interval. But if it takes longer, that is how you can recognize long QT quickly without a lot of measurements on the EKG. Okay, this is a case of an 11-year-old female who has occasionally reported palpitations while playing soccer. At this time, she wasn't really feeling great. She collapsed while playing soccer. CPR was started. An AED was attached. It was at the bedside, at the at the game site, and she was shocked effectively into sinus rhythm. So you arrive on the scene, and your next step is going to be early EKG. So in this case, she has a condition called Wolff-Parkinson-White. And I want to show you this EKG and point out the abnormality on the EKG. I'll show you another one because they don't all look like this, and then we'll talk about the electrical implications. So here is the P wave, and you can tell that there's no flat line in between, and it curves directly up into a QRS. So you have a short PR or non-existent PR interval between the end of the P wave and the beginning of the QRS. And then you have this little triangular area down here in certain leads that is called the delta wave. And that is how you can recognize WPW. It's not typically visible if the patient is in SVT, and certainly not if they're in V. Here's another EKG where you can see it's a little more subtle. There's the delta wave, the P wave going directly up into the QRS. And be sure to examine all the leads because you can see it here in the mid-precordial leads and in the left lateral leads. You see a little triangular type delta wave. And here's a good example from a Holter monitor where the first 3 beats have Wolff-Parkinson-White visible. So the P wave slurs right up into the QRS, and here you see that that pathway that causes that rapid depolarization of the ventricle is silent, and you see a normal QRS complex. It was once thought if WPW was intermittent that it didn't have as severe implications, but now that's sort of being questioned. So this is what's really happening. In the normal heart, you have a sinus node which generates an electrical impulse that travels through the right and left atrium. And then to get to the ventricles, it can only travel through the AV node, the bundle of His, and then into the Purkinje fibers into the ventricle. And that is how depolarization occurs in the normal heart. In the normal heart, you can think of these 2 valve rings as being a fibrous structure of the heart, and they should be completely electrically isolated. But in Wolff-Parkinson-White, there is an area along one or the other of the valve rings that allows conduction to occur from the atrium to the ventricle in sinus rhythm. And in tachycardia, typically it allows that signal to rather than dying out at the end of one beat, it recirculates back up to the atrium, and then you have this, what is called a reentrant circuit. And tachycardia is typically narrow. This is the normal sinus rhythm in a normal heart on the far left EKG. This is what Wolff-Parkinson-White looks like when the ventricle is experiences early depolarization because this pathway or this accessory pathway is so fast conducting. The danger of Wolff-Parkinson-White occurs when a patient has ventricular fibrillation, which is just erratic atrial activity and a pathway that can conduct much faster than the AV node. And so in that situation, the atrial fibrillation, which is an irregular rhythm, can conduct rapidly through the accessory pathway down to the ventricle. And so the mechanism of sudden cardiac death, which this 11-year-old experienced on the soccer field, the atrial fibrillation leading to ventricular fibrillation leading to death. And it's not super common that kids experience sudden cardiac death with Wolff-Parkinson-White, but it can also be the first symptom. And I guess it's less likely because atrial fibrillation is relatively unusual in kids, but in fact does occur at times. So that's kind of a whirlwind. We're not going to talk about any other cases in the interest of time, but I do want to hit on a few strategies for improved survival in pediatrics and then just summarize the talk. There's a lot written about the chain of survival, and although the chain of survival is not clearly defined in the literature, there are varying definitions, but it's pretty well accepted by the American Heart Association and others that with recognition and prevention being at the forefront, if pediatricians can screen for kids who might have heart disease, and if chest protectors were actually protective, if if we sort of anticipate certain situations, then that's the first part of the chain of survival. Early call for help, and we know that EMS typically gets to the scene within minutes. But it's important to have high quality CPR and early defibrillation, as we saw in the case of Damar Hamlin. He had immediate and expert resuscitation, which allowed him to survive his event. So if we look at these, recognition and prevention, high quality CPR, and early defibrillation, those are three that I think are sort of on the forefront of saving. From an EMS standpoint, remember that your first assessment is very valuable. What you saw, what people reported, because you are the eyes and ears of you know, of what happened and bringing that information with the patient. Then early EKG. Now, just as you may have a patient who had a syncopal event or had a seizure, that early EKG may show changes that especially in kids will correct rather rapidly. You have a role, I think, in increasing community awareness for pediatric CPR and talking in schools, being ambassadors for people taking it upon themselves to learn CPR. And then widespread use of AEDs. Knowing where these are in the community is another initiative for the chain of survival. And then lastly, in cases which might not be cardiac, your situational awareness at the scene, drugs or potential for child abuse or other situations can be super helpful to providers who receive these patients in the emergency department. So after this whirlwind review, I want to say that this is a sudden cardiac death in pediatrics and sudden cardiac arrest are low incidence but very high impact. Often they're exercise related with no known pre-existing condition. Pump failure, electrical failure, or valvular obstruction can be sort of broad categories that you can think of when trying to figure out why a patient experienced sudden cardiac death. Primary prevention is always the best, but early CPR and defibrillation have probably the biggest role in saving lives. I'd like to thank you for your attention and for inviting me to give this lecture.